understand what TEG is and why we use it. We got some background of massive transfusion and why we use it, and some literature of what we do and why we do it. So, trauma is my job, leading cause of death between ages of 1 to 44. Major people die from trauma because they have hemorrhage, uncontrolled hemorrhage, and that leads to 30-40% of all trauma deaths. And about a third of our patients present to the emergency room with a trauma-induced coagulopathy as well.
If you aim it, it should be.
So this is what we try to prevent in the OR. So we talk about a triad of death in the OR, which is cold, coagulopathic, acidotic. And in these patients, you want to control those three areas. If you don't, the patient dies. So the bloody, vicious cycle we always talk about, we're trying to prevent this. As you see, everything is sort of all tied into one. Patients are exposed, they've been outside, their core body temperature drops, they are in shock due to the hemorrhagic shock that they're in, and the tissue injury has occurred, increases the inflammatory mediators in the body. Those clotting factors that are used, you go into metabolic acidosis, you become coagulopathic, and everything gets worse. Your liver does not produce clotting factors if it's below 34 degrees Celsius. So if I'm in the operating room and the patient is below 35 degrees Celsius, we put a bunch of packs, we close the belly, we get tail out because I can't fix the bleeding at that point in time because the body's cold. We do everything we can do to prevent patients becoming cold. Trauma-induced coagulopathy is associated with increased risk for massive transfusion and multiple organ failure. It's also indicated. It's also been shown to increase our ICU days and overall length of stays, and your mortality is fourfold higher. So again, it's one of our major goals: keep people warm, keep people with a normal lactate, and prevent them from going into a coagulopathic state. Trauma-induced coagulopathy is underestimated because almost every one of our patients is in it to some degree. Standard coagulation tests fail to accurately describe the true extent of this, and the traditional etiology of why is because the patients are hypothermic, acidosis, and coagulopathic because we've used all of their coagulation factors. Etiology of trauma-induced coagulopathy is again cold, coagulopathic. The acidosis is caused by a hypoxic state leading to shock. It inhibits the rate of our body's ability to produce thrombin. Patients are cold. We talked about the liver does not produce clotting factors if it's less than 34 degrees, and then we've given patients fluids, bloods, and we decrease their overall circulation volume of the coagulation factors. Hyperfibrinolysis, meaning that clots are being broken down faster. Our bodies are always in a state of building clots and breaking down clots. When a patient develops a PE, that means that they're on the side of in a hypercoagulable state, and they're making more of the clots. And these trauma patients are in a more of a hyperfibrinolysis state when they're breaking down more clots, and these patients bleed easier. And DIC from massive transfusion factor release is seen in burns and concussion injuries and brain injuries due to the massive release of tissue factor, which causes a consumptive coagulopathy. So in the OR, when we arrive in the OR and somebody has a massive gunshot wound to the belly and we're in there trying to fix it and they become cold, coagulopathic, and acidotic, our major goal is to get out of the OR the quickest as we can, control the major surgical bleeding we have, get them to the ICU so we can warm them up, fix what's going wrong, and then as soon as things are fixed, take them back down to continue on with what we're doing. You guys in the ICU see it all the time that we'll come back up with somebody packed and we'll take it back the next day or the day after. The reason why is that we're unable to control the tiny, minute oozing, bleeding that's going on. The body has to do that itself, and if the body's cold, coagulopathic, we cannot do it. This is just a little sign that in trauma patients, we allow for permissive hypotension for patients who are taken from the trauma bay to the OR. Permissive hypotension saves lives because we don't want somebody with high blood pressure who is actively bleeding. So there's been a role for this permissive hypotension upon going to the OR. MAPS of 55 is okay to get someone from the trauma bay to the OR because it allows for the bleeding not to be such a large amount, prevents as much blood loss, prevents as much heat loss, therefore the patients do a little better. It's just some studies that prove that we're doing that. Again, just a study that shows the randomized control trial says that to keep patients' MAPS between 50 to 65 is good because we have the ability to decrease use of blood products, overall improve coagulation and keep patients warm. Studies that just prove all that. This is going on to the fact of fluids. When we give someone fluids, to understanding that even though we're giving somebody 2 liters of fluid in the ICU, they're only basically going to receive 2/3 of the amount of that, or one-third of the amount of that fluid. Everything we're giving to the body, you're only getting 1/3 of that into the intravascular volume. If you bolus someone with 1 liter of fluid, they're actually only receiving 300 cc's of that. Y'all in your training been around some other doctors that would bolus patients with 250 cc's of fluid because they're concerned about their heart. If you bolus someone with 250 cc's, you're only receiving 80 cc's of fluid. Our body circulates 5 liters of fluid. That's just basically over just 10% of their, just over 1% of their body's fluid. It's spit in the wind. If you're going to bolus someone. 80 cc's of fluid, nothing. On a patients arriving to the trauma bay, we always get the question, do you want normal saline or LR? LR is our choice of fluid. LR. The only patients that should not receive LR are patients that you know that come in with a dialysis port who have hyperkalemia when they arrive. There's really no other incidences to ever give someone normal saline over LR. Even though there are studies that say that normal saline and LR is normal, at the end of the result, LR was showing that it is a better fluid for all comers. So if I have a choice of fluid, we use LR. Okay. So this hospital now for many years has a program for the massive transfusion protocol. It's to avoid patients dying from massive hemorrhage. It's allowing us to get the blood and products to the patient as quickly as possible. It's been shown through studies to save lives. As we've all seen in the ICU and trauma, we activate massive transfusion, blood products of blood, FFP, and platelets arrive in big, huge buckets, and we can give it as fast as we can to save people's lives. Basically showing that the role of the use of FFP and platelets combined with the role of blood products have been shown to save lives. If you're bleeding out, if you're dying from whole blood loss. The best way to treat that is to give whole blood back, giving FFP, platelets, and blood. This all came from the studies from wars where when they were transfusing soldiers, whole blood from one patient to whole blood to the other patient, these patients did well. We took that info, we transitioned that to civilian life. And this is basically showing that the role of using FFP, platelets, and PRBC at a 1-to-1 ratio has been shown to save lives. The role of damage control, resuscitation, going to the OR, doing as much good as you can in the shortest period of time, getting patients out of the OR so they can get warm, save lives as well, and decreasing the role of blood product utilization. So we thought that the role of FFP, that if we just gave patients FFP, it would help to correct the coagulopathy. However, we found that giving too much FFP has a negative effect and not giving enough. So we found that we give the patients what they need. If you're given blood, you give the appropriate amount of blood, FFP and platelets every time. Not more, not less. Give them what the patient needs. But still, there have been some problems with what is the at that exact amount we have to give. And that's where TEG comes into play. So overall, some summary data on massive transfusion protocol. It's very, very great for trauma patients. There's no randomized controlled trial because you're not going to say we're going to give something that we know benefit to some people and not give it to another. There's not going to be a randomized controlled trial because it would cause death in other patients. So we're not going to be able to do that. We know it works. We have data that supports it. But we continually ask, is it good and why? We still try to advance it. There is a significant survival bias in about half of the studies, meaning that we believe it does better, so our studies are created to show that it does better. We do need to do more research on this to ensure that we are doing what is right, but however, we all believe we're doing what is normal right now. As medicine goes, at some point in time, we're going to find out a better way to do that, and that's how we came up with TEG. This is just basically saying how do we come up with massive transfusion and what type of ratio that we use. Patients who had a lower ratio of a 1 to 2 ratio of FFP to platelets and RBC were 3 to 4 times more likely to die than the patient with 1 to 1 to 1. That's how we determine that the 1 to 1 to 1 ratio is the best. Same idea. On the battlefield, they store whole blood, or you're set next to somebody with the same blood type as you, and you're transfused from one patient to the other, whole blood to whole blood. Their survivability in the field is a lot better than the survivability we have in the hospital. Our blood that we get here is anywhere between 15 days and 45 days old. If you get the good blood from 15 days old, you're going to tend to do better than you get the old blood that's 45 days old. There's no way that we can overall improve that because our blood, the amount of stored blood products we have in the United States is low. There is always a need, and so they triage the blood to go in areas where it can be used the best. Level 1 trauma centers get newer blood because we use it faster. Places that don't use a lot of blood, I'm sorry that they get old blood. We need more active blood than other patients because we go through a lot of blood. All right. So we did massive transfusion for years and years and years, and we just gave a 1 to 1 to 1 ratio. However, we decided that are we wasting blood products, and the overall utilization of blood products with MTP is higher. So we started adapting this thing called TEG, and TEG is a thromboelastogram. And I'll show you some diagrams of how it's made and how it's used. But what it's going to tell us is after you give your first round of 1 to 1 to 1. You run a TEG, and basically a TEG is telling you what does the body, this person's body's clotting factors look like. And it tells you how the clot is working and what the clot is actually doing. And you can give specifically, do they need FFP, platelets, or do they need cryo? And that's what the TEG is telling us. So it minimizes the amount of wasted blood product usage because we're giving the body exactly what the body is telling us it needs. Overall, the study showed that TEG-guided resuscitation is better than just MTP alone because it decreases the risk of the overall use of blood projects, and it decreases the overall mortality of patients because we're not overloading the patients. We use massive transfusion here, and there's a reason why we do it, and I'll cut to the chase on why we use it. If someone comes in who's actively bleeding, who's hypotensive, who's going to the OR, they're going to get massive transfusion because it helps us to get the blood products in the patient as early as possible at the amount that we need. So someone, gunshot wound here, hypotensive, going to the OR, they're getting massive transfusion. They also get massive transfusion. If I see the wound is over top of the liver, I expect there to be a lot of blood. I'll activate the massive transfusion. I'll get the blood in the room. I'll start giving it to them, and then I can always stop. I can always stop. I can always stop it. There is a role of activating it for people who are in hemorrhagic shock, what you do. It's also a physician guided order to say, I know I'm gonna have a problem, let's get everything I need now. There is a difference between massive transfusion and emergency release blood. I can also in the trauma base say, I need 4 units of blood released now, type 00 blood. That's not massive transfusion, that's just 4 units of blood released. Massive transfusion means the blood, the FFP, and the products. Okay? This is the MTP flow sheet. We'll go through this, I just put it up there. So when we order the massive transfusion, the blood should come in all one big box with 6 units of blood, 6 units of FFP, and 1 pooled plate, which is basically 6 to 10 units of pooled platelets. Then we draw labs. We get an QQ panel to check our clotting factors. We check an ABG with the calcium as well as in your coagulation cascade, so we always check an ABG with the calcium. The ABGs help us to find our lactate and also to tell us what our calcium is, and then we get a TEG every batch. And a TEG will start running. It's actually an active process that we can see in the operating room of an active tracing of how a clot looks. We'll show that right now. This is basically just saying if we just keep asking, the blood products will keep arriving. I don't need in the operating room to say, keep bringing blood. They will keep bringing blood until I say stop. So they'll keep bringing the products I need until I say stop. But we're trying to use the TEG to guide to say, stop massive transfusion and bring the products I specifically need. And that's what we're trying to do with our TEG. The traditional studies that we look at is we look at the PPP, the INR, and our platelets. However, that's telling us that at one moment in time what products that we need. It doesn't overall estimate what's the ongoing process in the body. Fibrinogen levels ordered during a trauma case can be useful sometimes, but other times it's not because they can change minute by minute. We check them with our massive transfusion protocol to get a baseline levels to figure out as we resuscitate the patient, are we getting better or worse? And the TEG helps us with this as well. So TEG, thromboelastogram. It's available within minutes. If we draw the TEG, your vial of TEG, we send it down, we should have some numbers generating within 5 to 15 minutes. And what it tells us is dynamic information based upon the speed of how well the clot grows, how the growth is, what is the rate of growth of the clot, how strong is the clot, and how fast is that clot being broken down. This is what the initial TEG graph looks like. We have the initiation part, which is the first smooth line. How long does it take the clot to form? And then the angle of that first line going up, the angle of the first line going up is how fast the clot grows. Then maximum clot growth is at the top. And then how is the clot degrading over time? And this is when the clot goes back to the beginning point. So the bleeding time, when we used to check the bleeding time for our von Willebrand patients, we check the bleeding time, and that's basically telling us how the clot is growing. So the bleeding time is corresponding to our rate up. Platelet count is also involved on that because platelets need to aggregate to form a clot, and so that's part of the platelets. D-dimers, these are the breakdown products. Once the clot has been formed, now it's starting to break down. So these are the breakdown products of the clot. And overall, at the end of that all is your hemostatic status. How fast and how well is your clot being made, and how fast the clot is being broken down. This is what a TEG machine looks like. The TEG machine, basically you put in a drop of blood, 0.36 mils in there. There's a cup that holds a pin, and what happens is this pin spins around, basically stirring up the blood to produce a clot. Easy. So this is what a TEG trace looks like in the OR. That picture down there is what we see in the OR. And this is showing us that this doesn't have a This is how long it takes for the clot to form, the rate of growth of the clot, is the maximum clot good, and how long it takes to break down the clot. And all these gives us information in the operating room of what products we need. The TEG system shows the entire process. This continuously goes through the time that we have it run. We watch this and can adjust on a minute-to-minute basis of what we need. So, the first thing we look at it is the R time, which is the reaction time. It's normally 4 to 8 minutes. If there's a defect in this, if it takes longer for the clot to form, so 10 minutes, it will show up on our screen in the operating room as red, meaning that there's a problem with it. To fix an R time, to get a clot to form faster, you need to give FFP. You need to give plasma. You need to give plasma. The angle, the rate of clot growth. You want the angle to go up at this set angle. The computer measures this angle for us and tells us is it on a curve or off a curve. And this is where we would use cryo. If the alpha angle and the K are off, meaning that they're not growing at a fast enough rate, we need to improve the ability for the clot to function. So this is where we are going to use our cryo. The MA. This is how well your platelets are working. This is saying that if this line is not high, it's not getting big, that means that we need to give platelets to fix this. So the R is the FFP. If the R is too long, it means that the clot is taking too long to form. If the rate of growth, the A and the K are not in line, if the A is taking a long time to form the clot, and the degree of the rate of the clot for formation is slow, we need to give cryo to help with that. The MA, the total width of the clot, if that is altered, we need to give platelets. And then, once the clot is formed, after the MA is formed, the next thing is how fast is the clot being degraded. If the clot is being degraded really fast, this is why we give TXA. The TXA drug that we give in the trauma bay and up in the trauma ICU is a fibrinolytic. It's an anti-fibrinolytic medication that prevents fibrinolysis. It inhibits the conversion between plasminogen and plasmin so that the clot is not being broken down as fast. That's how TXA works. It prevents clot breakdown. So this is what this graph should look like in the OR. This would be a perfect graph that we wouldn't have to do anything to it. So when someone's bleeding, this is a printout. This is a shot from our from the OR of how it looks. It gives you the numbers on the bottom, and right now the numbers are all fine. This hasn't completed the whole tracing, but that's the way it comes out. It looks. It shows the R. His R time, if you go by the numbers there, his R time is 14.1 minutes. That means it's way too long. So this patient needs some FFP. His K is good. His angle is good. His MA is good, and his lysis hasn't got to the lysis part. So this patient would be ordering more FFP because his R number is 14 and the normal is between 4 and 9. This is idiot proof. The computer we have in the OR actually rings red and the one that you need to fix too, which is quite easy. So this patient here, this is continuing with the same tracing. His R is 4.6, which is good. His K is 2.8. He's 55.6. So the angle, the rate is low. So he's going to get a touch of cryo. He's going to get a touch of cryo. 48.3. He needs some platelets. So this is the same patient that they gave FFP to. He improved, but now with the ongoing bleeding in the operating room, he has now lost the ability to produce the clot at a good rate, and the strength of the clot is poor. So now they're going to give cryo and platelets. This is how it looks when the clot starts to break down. And this is the primary fibrinolysis. This is a patient that did not get TXA. As you can see, the clot was formed, it was made, everything looked good there, and then the clot collapsed upon itself. This patient is breaking down more clot than he's making, and this patient is dying because he's bleeding from the inability to keep clotted. This patient needed or needs TXA. This patient isn't as bad as the last patient. He's making a clot really fast. The growth of the clot is good. The strength of the clot is good, and he is barely breaking down his clot. He is breaking down his clot a bit. As you can see, it's 12.5 and a normal 0.8, but he's not dying from an active fibrinolytic pathway. He either received his TXA or didn't receive a second dose, or this is going to become a consumptive coagulopathy because he's going into the second stage of DIC. Massive hemorrhage, what we do in trauma. You also see it in GYN cases, especially OB/GYN cases, preeclampsia and HELP. Amniotic fluid embolisms seen extremely in those due to the massive inflammatory reaction that occurs when amniotic fluid enters into the bloodstream. And anything that damages the liver can result in a DIC process. DIC is a consumptive coagulopathy, which first of all starts with activation of the coagulation cascade, and increases your fibrin deposition and increases thrombus in the small vessels, resulting in tissue ischemia and organ failure, and also at the same time as decreasing coagulation cascade factors, which result in bleeding. That's why DIC results in death, and you need to aggressively fix these patients. TEG can now help us with this in a patient going through DIC to tell us what is going down faster and fix the ongoing problem rather than just dumping a bunch of fluid in there that isn't really helping. We want to know exactly what coagulation factor is going down and how we can fix. Progression of DIC, so the hypercoagulation phase in DIC, we want to treat what the underlying problem is. Is it sepsis? Is it trauma? Is it bleeding? And at that point in time, we can see that our R number is good, our K number K number is okay. The angle is almost at its max. The MA, the clot strength is good because we're in a hypercoagulable state, and the fibrinolysis is good. DIC first starts with a hypercoagulable state. As we can see, that clot is strong and big and good. Then fibrinolysis takes place. As you can see, the graph starts to trend down, where fibrinolysis is taking over from clot formation. We need to decrease the fibrinolysis of the patient. This is a time where you would use a TXA. Then, as DIC progresses, you get into the hypocoagulable state. As you can see, the difference between the first graph and the third graph. Taking time to produce the clot, the height of your curve there is extremely low. You're not making a good clot. It's taking longer to make the clot, and we are degrading our clot fast. So these patients are dying because they're actively bleeding because they cannot form a clot. Again, it's showing you the same thing. The hypercoagulable state at the beginning is telling the body now that it needs to fix the hypercoagulable state. The body releases its fibrinolysis enzymes, which start the activation of secondary fibrinolysis, and activating this causes a consumption of platelets, and therefore your clot is not as strong. You can see the progression of how it goes. And that's it. So what we learned from TEG is that TEG allows us to specifically treat what is the underlying problem to clot formation. And clot formation allows us to treat these bleeding patients not with an empiric algorithm of just give blood product FFB cryo, but gives us a stepwise process of what to give and why to give it, and treat each patient individually. It's been shown to save lives. We are trying to use it more here. Dr. Watson has been a proponent to use it in our ICU patients. even when they come back from the ICU, to not just keep giving 6, 6, and 6, but to give what they specifically need. And so we're trying to, as a group, to try to do this much better. I was told that we wanted more education on this to understand. I have some graphs and stuff that I'm going to print out and hand out on rounds tomorrow on this factor. That'll give you guys a cheat sheet of what we're doing. So when we run the TEG, you can pull out of your books and you can see why we're doing what we're doing and ask better questions of why we aren't doing this, this, and this. Fair deal? Questions? Yes?
Dr. Moore, thank you so much for this talk. Tina, I work in the ER.
Okay.
Just a quick question. How long does the TEG analysis run?
It can run for a long time. Like it can continuously run through your entire thing because it's an active thing of the clot. So we normally run it for 15 to 90 minutes. By that time we already have our secondary one going because we keep running a new TEG for every massive transfusion protocol that we give. So we run it to see when the fibrinolysis starts. 30 minutes, after 30 minutes, in my mind, I stop caring what that one does. I'm ready to go on to the next one to see how well we are doing.
Okay, so I guess essentially after each batch then?
Each batch, yeah.
Okay.
Yeah. In cardiac surgery, where I was trained, they would get one every 30 minutes because the body's changed every 30 minutes. So it takes about 30 minutes to get to the lysis 30 to get to the fibrinolysis pathway. So you want to see through your fibrinolytic pathway, and the clot starts breaking down. That's when you get your next one. So cardiac surgery, they would get one every 30 minutes, and they would just run them consistently in the bag. Yeah.
How quickly will you see the changes in the TEG for DIC?
The hypercoagulable state almost occurs immediately. You'll start to take with that. You'll see how it'll be. You'll see how it'll be a hypercoag, and then if you don't treat the underlying problem, sepsis or hemorrhage, that process gets there fast. You'll probably see it within 30 minutes to about an hour and a half from the incident to the beginning of the belief that DIC began. Because you've seen it in your patients, like they go from going, there's some oozing coming out of some JPs, or they're not looking well, to, holy shit, we're in trouble.
What does dilution, pre-hospital dilution affect this?
Pre-hospital, you mean like 2 liters of fluid in the
2
field
or
and stuff
3
like that?
2 or 3 liters of fluid coming in. Does it
Doesn't.
affect this thing?
It affects the overall prognosis of the patient. Too much fluid pre-hospital, pre-knee causes problems. I want them to give fluids to maintain a map between 55 and 65 for permissive hypotension in severe blunt trauma patients. Keep them with an adequate blood pressure, but they need blood, and blood. If someone's losing whole blood, I want them to get blood. I don't want them to get LR. I don't want to get them normal saline. If you're losing blood, you need blood. Give all the fluid you want. It doesn't have oxygen carrying capacity.
Good one. TEG versus rapid TEG.
Same thing.
It's the same thing. Okay.
There's multiple different versions of what a TEG is. There's multiple, it's just TEG. We have a TEG machine here. They call it rapid TEG because it works fast, but we just use TEG. Yep.
Where is our TEG machine? Is it in the lab or
It's
just
in the lab. It's in the